Welcome everybody. This is our 6th out of 8 webinars. Today's topics are catheter-directed thrombolysis for iliofemoral DVT and pelvic congestion syndrome. We are very lucky to have with us two distinguished speakers, Dr. Anthony Camarota and Professor Mark Whiteley. Both are experts in their fields and they are excellent speakers. I'm delighted to introduce our panelists who are going to ask key questions to the speakers, and Dr. Suat Dugansi, who is going to select questions from the Q&A box and transfer them to the speakers. This scientific event has actually created a bridge of collaboration and professional friendship with our colleagues in Latin America and in Africa. And we are delighted to have with us today Dr. Marcial Fallas as our honorary chairperson. He is Vice President of Costa Rica Vascular Surgery Association. We cannot proceed without thanking the WIN Foundation with its three masters, Sergio Giannassini, Oscar Bottini, and Willie Shee. They gave infinite, unlimited support to this educational event. Your questions written in the Q&A box will be submitted to an international committee who will select the winning question. An award is waiting for you. Finally, I would like to thank our sponsors, our platinum sponsor, Servier d'Aflon, our gold sponsor, Medtronic, and Biolytic, ECS, Medi, and ProMed, our support sponsors, without whom this would not have been possible. Now I would like to introduce our first speaker, Dr. Anthony Camarota. He's the medical director at Innova Heart and Vascular Institute. He's director of the medical research and director of the vascular laboratory. But most important, Dr. Camarota, as we all know, is the father of the early thrombus removal strategy for iliofemoral DVT, and he's the principal investigator of the ATTRACT trial. Dr. Camarota has visited Egypt in 2014, and I think his visit was remarkable and has changed the practice of many of us. Dr. Camarota, please go ahead and share your screen. Share your screen, Dr. Camarota, please.
Do you see it?
Yes.
Perfectly well, yes. Yes,
Yes.
Dr. Camarota, perfectly well, yes.
Well, first of all, thank you for the invitation to be here, and thank you for the very kind introduction, Dr. Bishara. I have had an interest in the management of iliofemoral DVT throughout my career, and now we're going to have a discussion that reviews randomized trials for its management. We have one trial on technique, and then we will focus on the ATTRACT trial because it is the largest study to date addressing this issue. These are my disclosures. So when we look at iliofemoral DVT and its management, of course, we always want to prevent pulmonary embolism. We want to relieve the patient's acute pain and their edema, reduce post-thrombotic syndrome, which is much worse in patients with iliofemoral DVT than other lesser forms of deep venous thrombosis, and then obviously reduction in recurrence. And I want to actually show what it is that we're dealing with. I'm using this patient who just underwent a major operation on her spine and then developed a phlegmasia cerulea dolens, and this was her ascending phlebigram, showing that all named veins were occluded, and obviously we could not use thrombolysis in her, so we decided to do a standard surgical thrombectomy. And here you can see the common femoral vein with its transverse venotomy, the saphenofemoral junction, the femoral vein, and you can see how laden that common femoral vein is with thrombus, and you can see the exceedingly large burden of clot that patients have with full-bore iliofemoral deep venous thrombosis. Now, if we don't remove this, what happens is that acute clot will evolve to collagen. And this will be the result, and this collagen will result in occlusion of the venous outflow, leading to very high venous pressures, leading to the classic end-stage sequelae of the swollen limb, the painful limb, the discolored limb, and in some patients, eventual venous ulceration. So in this woman, restoring unobstructed venous drainage to the iliofemoral system into the vena cava leads to a very good outcome. And this was a photograph of her 3-year follow-up where she had no edema, she had normal valve function, and she basically was asymptomatic. Susan Kahn and her colleagues in a prospective observational study demonstrated that patients with iliofemoral deep venous thrombosis have a very, very high risk of post-thrombotic syndrome, and they demonstrated an odds ratio of 2.23 relative to other lesser forms of deep venous thrombosis. As part of the National Venous Registry, we demonstrated in a cohort-controlled study that patients who were offered catheter-directed thrombolysis had a significantly improved quality of life over the long term compared to those patients treated with anticoagulation alone. And then we've all seen and we've all cared for patients like this, a terribly swollen, painful, bluish discolored leg in an iliofemoral DVT patient treated with anticoagulation for 5 days. And we can appreciate the pain that he is having, the very extensive occlusion of the venous outflow by this acute clot. But once that clot is dissolved and an underlying stenosis revealed, as it was here in the left common iliac vein, the classic May-Thurner anatomy. And once that is treated, you see the frame on your right, restoring unobstructed venous outflow, this patient can expect to have a very good outcome. And his 36-month follow-up study had normal valve function, no evidence of edema, and was fully asymptomatic. And these are excellent anecdotes, but we do need randomized trials for guideline writing committees to fully integrate the information generated by randomized trials into their recommendations of care. So we do have one technique-related randomized trial, and that was performed by Engelberger and his colleagues on ultrasound-assisted thrombolysis versus conventional drip technique for iliofemoral DVT. And they asked a very simple question, does intravascular ultrasound facilitate the resolution of thrombus during catheter-directed thrombolysis? And they had a very elegant but elegantly simple protocol. And they took 48 patients with iliofemoral DVT, randomized them to conventional catheter-directed thrombolysis using an ultrasound catheter, but they did not turn the ultrasound on, versus ultrasound-accelerated catheter-directed thrombolysis, the same catheter with the ultrasound turned on. They treated each patient with 20 milligrams of TPA after 15 hours, and then calculated the percentage of thrombus resolution. And they quantified very carefully the amount of thrombus in each patient. And their results were that there's absolutely no benefit from adding intravascular ultrasound to regular drip technique catheter-directed thrombolysis. Very important study by Engelberger and his colleagues. But let's look at those randomized trials that adopted a strategy of thrombus removal for iliofemoral DVT, specifically addressing post-thrombotic morbidity. Now, Gunnar Plata and his Scandinavian colleagues performed a randomized trial of surgical thrombectomy versus anticoagulation alone, and they followed their patients very carefully at 6 months, 5 years, and 10 years. and demonstrated that those patients randomized to thrombectomy had improved patency rates, lower venous pressures, less leg swelling, and fewer post-thrombotic symptoms compared to anticoagulation alone. And these are level 1 data. El-Shawari and his colleagues performed a smaller but nicely performed study looking at catheter-directed thrombolysis versus anticoagulation on patency of the iliofemoral system and normal valve function. And you can see that patency was significantly better in the lytic patients and normal valve function was significantly better, 72% and 89% respectively, in those patients offered catheter-directed thrombolysis. And then Tuna Endon and her colleagues asked the question, is there any long-term clinical outcome, is long-term clinical outcome dependent on lytic success? And they performed a randomized trial of the addition of thrombolysis to standard of care, that is to anticoagulation, to evaluate the benefit of CDT versus anticoagulation alone. And they demonstrated that in those patients randomized to CDT, 82% was the resolution of the clot. That's an enormous amount of clot resolution. They did have 3.3% major bleeds. Only one patient had an IVC filter, and no patients had a symptomatic pulmonary embolus. And what they found was that iliofemoral patency was significantly better in those patients who had additional CDT, and post-thrombotic syndrome was significantly less at 24 months. So there was a lower thrombus score at the completion of CDT, which was associated with improved patency, and iliofemoral patency correlated with the reduction in post-thrombotic syndrome. Initially, at 2 years, the number needed to treat was 7, but as one follows these patients to 5-year follow-up, those treated with anticoagulation had progressive deterioration, whereas that was not the case with CDT patients. So at 5 years, the number needed to treat to avoid one post-thrombotic syndrome was 4. So the ATTRACT trial was, the overall trial was published in the New England Journal, and Suresh Vedantam was the overall PI. And this was an NIH-sponsored study. And the primary endpoint, and one could argue that this was appropriate, but the primary endpoint was any post-thrombotic syndrome at 24 months, meaning a Villalta score of greater than 4. I want to emphasize that patients with proximal DVT were stratified at entry, and once they were stratified to iliofemoral DVT or FEMPOP DVT, they were then randomized to catheter-directed thrombolysis or anticoagulation. Secondary endpoints were moderate to severe post-thrombotic syndrome, and we see that there's no difference in post-thrombotic syndrome using any PCDT, any post-thrombotic syndrome as the primary endpoint. And this drove patients' opinion, but in reality, catheter-based strategies of thrombus removal are really focused on iliofemoral DVT patients, and therefore we took the iliofemoral DVT patients and did a primary analysis on them. 391 with iliofemoral DVT, same randomization, same primary endpoint, same outcome, as you can see, using the Villalta score. Had we chosen the venous clinical severity score instead of the Villalta score, we would have had a positive primary endpoint with significant reduction in post-thrombotic syndrome. I want to point out one other important observation here, and that is at entry into the study, 14% of the patients had a normal Villalta score in the ATTRACT trial. You can't improve someone with a normal Villalta score, and 33% had a mild Villalta score. So 47% either had a normal or a mild Villalta score at entry. As I mentioned, 14% normal. However, if you look at the overall Villalta score post-treatment, significant reduction in the PCDT patients compared to the control. If we then look at moderate to severe post-thrombotic syndrome, significant reduction in moderate to severe PTS in the CDT patients, significant reduction in severe post-thrombotic syndrome. And isn't that what we're trying to do? Reduce moderate and reduce severe post-thrombotic syndrome. There was a 1.5% incidence of major bleeds compared to 0.5% in the control group, with no intracranial bleeding. And there was a significant reduction in pain, a significant reduction in edema at day 10 and day 30 in the patients receiving PCDT, and a significant improvement of disease-specific quality of life. So pain, edema, quality of life, severe post-thrombotic syndrome, moderate to severe post-thrombotic syndrome, these were all significantly improved. So the primary endpoint, reduction of any PTS, was not met, but remember the other observations. However, compared to no PCDT, the PCDT patients had a reduction of any post-thrombotic syndrome using the VCSS score, reduction in moderate to severe, reduction in severe, reduction of pain and swelling, and improved disease-specific quality of life compared to controls with an historically low risk of major bleeding. Thank you once again for the opportunity to join you today.
This was excellent. Thank you very much, Dr. Camarota. We really appreciate it. And Dr. Wasila, our secretary of EVLA Foundation, could you please introduce our panelists?
Yes, Dr. Rashad, but not before congratulate Professor Camarota for such an excellent presentation, and really deeply thankful for your valuable contribution, Tony. We're really glad having you among us this night.
Thank you.
And welcome everyone on our sixth night. I'm truly honored to introduce our first panelist, Professor Larisa Chernukha from Ukraine. She is the Chief Researcher Vascular Department in Ukraine and Vice President of Association of Vascular Surgeons, Phlebologists, and Geologists in Ukraine. Professor Chernukha, the podium is yours now.
Thank you very much, Vasilia Daha, for introducing me. Thank you very much for the opportunity to take part in the wonderful webinar and the wonderful lecture by Professor Camarota, as always. May I start with some comments? On the one hand, in the design of trials, it is necessary to compare not only treatment methods, but also to select patients with the most homogeneous DVT, not only in terms of localization and spread of thrombosis, but also taking into account modifiable and non-modifiable patient risk factors in order to obtain correct research results in the future. On the other hand, the treatment of iliofemoral DVT is determined by the professional and technical capabilities of the doctors and clinics. Therefore, despite the excellent immediate results of the aggressive tactics, in real life, approaches with the use of anticoagulant therapy will certainly lead, and we observe this in practice. And the use of stent placement with thrombolysis is known to be an approach that brings enormous benefits and benefits for patients with an acute episodes of DVT in the presence of certain congenital conditions, for example, May-Turner syndrome. My question is whether stent placement is necessary in patients without a clinical pictures of DVT in the presence of ultrasound symptoms and CT, MRI data confirming the presence of the syndrome. And I think the question of the admissibility of performance stenting in the presence of developed collateral in the pelvis and trophic disorders on the limbs will be appropriate. Thank you.
Well, Professor Larisa, hello. It's so nice to see you again. And thank you for a very excellent discussion. And then your question really focuses on a very important issue that we have not answered. And the basis, say, if we see residual stenosis in the classic May-Turner anatomy, and I think that's what you were referring to, does it need to be treated to prevent recurrence over the long term? We don't know the answer to that. There's not been any good observational studies, let alone randomized trials. I think the opinion of many of the experts, at least here in the United States, is if we reveal an underlying residual obstruction, that will be treated by the majority of the experts in the United States because of the concept that residual obstruction will promote recurrence. The other concept is that stenting of a focal lesion in the iliac system, as long as we have good outflow and good inflow to the stent, these stents will perform very well, will be associated with excellent long-term patency and very few complications. So putting all those considerations together, unfortunately, I cannot answer your question based on data. I think we do have anecdotal experience that if we leave patients with residual obstruction, once they've formed a thrombosis, and once we've treated them for a thrombosis, if we leave them with some degree of thrombotic obstruction, they're at higher risk of recurrence. That has been our clinical experience. Again, no randomized trial data.
Thank you. Thank you.
Dr. Wasila, go ahead, please.
Yes, Dr. Rashad. And now we are truly honored to introduce Professor Sherif Assam from Egypt. Professor Assam, he is a professor of vascular surgery and endovascular surgery in Ain Shams University and fellow of the Royal College of Surgeons in Ireland. And Professor Assam he has a large experience of the complex endovascular for EVAR procedures, as well as for deep venous reconstruction. We are truly honored having you, Sherif Assam, in our night today. And the podium is yours now.
Thank you, Dr. Wasila. Thanks for all the panels. The honor is all mine. Thank you. I wish to also to thank Professor Comerota for this very comprehensive presentation. And I have just a very short and directed question now regarding this. If we are going to interpret the results of the ATTRACT trial based on the Villalta scale, so do we now start to take the decision when I have a patient with iliofemoral DVT? Do I put the Villalta scale as one of the prerequisites to decide whether to proceed for catheter-directed thrombolysis or pharmacomechanical or any form of thrombolysis or not? To make it more clear, do I categorize my patients into moderate or severe Villalta scale at presentation? So yeah, these patients will benefit from catheter-directed thrombolysis, or I hope that my message is clear.
Yes, and that's a very important question. Let me remind everyone that when we designed the protocol for ATTRACT, it was in 2006, 2007. And since that time, we have learned a great deal about post-thrombotic syndrome, post-thrombotic morbidity, and how we use the terms. The definition, and then we had to define what iliofemoral DVT was. Well, in some patients, if we have clot extending from the femoral vein into the common femoral vein, but it's not occluding the common femoral, it's just extending into, and there is a partial obstruction of the common femoral, that patient was classified as iliofemoral DVT. Now that patient might do very well with anticoagulation alone because there's a modest amount of edema and the thrombus that has blood flowing over it will likely resolve. And with good anticoagulation, that patient's likely to do very well. And we, when we've assigned a Villalta score to a patient like that, they were frequently close to normal or normal. So we can't improve upon the outcome in those patients with catheter-directed thrombolysis. The other reality is that in our clinical practices, patients with essentially femoral popliteal DVT with a modest amount of swelling, a minimal amount of pain, would be treated with anticoagulation. We would tend to choose patients with significant edema, marked discomfort, as patients that we would offer catheter-directed thrombolysis to. There's no question that when we looked at the patients with iliofemoral DVT, those that presented with significant signs and symptoms benefited significantly compared to those treated with anticoagulation. Obviously, if they had a normal Villalta or mild Villalta score coming in, they didn't benefit. And that was part of the inexperience of putting together a protocol like this at the time that it was written. I think if we were to put together a protocol today for the management of iliofemoral DVT, it would be quite different. And the other interesting observation was, as I showed, for the entire iliofemoral DVT group, had we chosen the venous clinical severity score instead of the Villalta score, we would have had a positive endpoint. So choosing the right tool is very important, as you can see.
Thank you.
Dr. Wasila, please.
Yes, Dr. Rashad, and now truly honored to have Dr. Veronica from Russia among us today. And she is from the member of the UIP Engagement Working Group. Veronica, the podium is yours now.
Hello, everyone. First of all, I want to thank Dr. Camarota for such an interesting presentation. For me, the data presented is especially important as in my hospital, there is about 1,200 patients with proximal DVT thrombosis per year. So my question is about the amount of patients in a routine practice that can be considered as eligible for thrombolysis. I mean, if we have got 100 patients with proximal deep vein thrombosis, in real life, then for how many thrombolysis could be applied, taking into account all contraindications? Are there any data on that subject?
There have been discussions about that, and that's such a good question. When we did, and I'm sure you're all aware of the paper by Clive Kieran publishing the outcome of our patients with femoral popliteal DVT in the ATTRACT trial. And there wasn't even a signal that catheter-directed thrombolysis improved outcome in patients with FEMPOP DVT. Now, there is a small segment of patients that I will continue to treat, and that is those patients who have very significant symptoms, swelling of their calf, and have thrombosed their entire popliteal vein and the popliteal venous trifurcation where the posterior tibial and where the perineal veins enter. Some of these patients are very, very symptomatic, and in those I would treat. They represent a very, very small percent of FEMPOP patients. In terms of those that have contraindications to lytic therapy, we're seeing now with the new technology that we have, that mechanical thrombectomy, aspiration thrombectomy, and now we have some thrombolysis catheters that can deliver a high volume of lytic solution at a low dose. So our doses are being dropped to less and less in terms of the milligrams of TPA that we use. We're infusing it at much larger volumes. We're getting much better outcomes. So the contraindication group is shrinking. especially when we see the benefits of mechanical thrombectomy in these patients.
Thank you. Professor Genesini, please go ahead.
Yes, now we have the honor of virtually flying to Istanbul, where of course we look to be for the next UAP World meeting. And it's my pleasure to introduce Professor Suat Toganji. He's really a leading figure in the field, so much that I think he could answer to all the questions that he's actually going to make for us. So Suat, please go ahead with the questions. Thank you so much.
Thank you, dear Sergio. First of all, I'm very grateful to be with all of these panelists and very extensive distinguished speakers. And also, we all know Dr. Camerato, and he made a very comprehensive presentation as always. And there was a lot of very good questions, but I selected the one which had the most likes from also the audience. The question is belonging to Dr. Ayman Alser. I think he's from Egypt. His question is, would you think if rheolytic devices were used in Attract, would it be effective in any PTS? Is it clear, Dr. Camerota?
Pardon me?
Is it clear, or should I read the question again?
No, you're talking about rheolytic thrombectomy.
Yeah, if the rheolytic devices used in Attract trial, would it affect on the results?
Well,
this is the question.
We did permit the ultrasound accelerated catheter as to be used if investigators wanted to use it, and we counted that as regular catheter-directed thrombolysis. We also had investigators choose if they wanted to use the trellis catheter or if they wanted to use the angiojet. So we had about a third of the patients receiving angiojet thrombolysis with additional catheter-directed thrombolysis if they did not exceed the 30 milligram TPA limit. We allowed them to use the trellis catheter with the same proviso, use the trellis catheter followed by catheter-directed thrombolysis with the drip technique with a maximum of 30 milligrams total, and then the drip technique. And we did not see any signal that any one of those additional catheters made a difference. The mean duration of thrombolysis remained about 22 hours across all of those three groups. So I hope that has addressed your question.
Thank you, Dr. Camerota.
Thank you.
If you wish, you could pick up another question. Siva, please.
And there was another good question. It was from Dr. Mohammed Ramadan. He says that, did Attract trial changed your personal practice in the concept of CTT as a preference to treat iliofemoral DVT whenever indicated?
Yes, and that is it really is the practical question, isn't it?
Yes.
The answer to that question is no, it hasn't, because it has demonstrated that patients who had a moderate Villalta score and those patients who had severe Villalta scores coming into the trial, they had significant benefit from catheter-directed thrombolysis versus anticoagulation alone. And in reality, those are the patients that are appropriately chosen for strategies of thrombus removal, no matter what they are.
Okay, thank you, Dr. Camerota.
I guess we could spend the rest of the webinar asking Dr. Camerota. Yeah. But unfortunately we can't. So now we have to move to the second part of the webinar, but we have 2 minutes away from science by Dr. Wasila. Dr. Wasila, please.
Yes, Dr. Rashad, we wish to congratulate Professor Mark Whiteley for the newcomer baby Stephen. Congratulations, Mark. And a new genius venous surgery on board now. Congratulations. And this is how we write his name in Arabic. Congratulations, Mark.
Thank you very much. That's lovely. He'll be very pleased to see that.
Thank you. Thank you. And now the second part of our social break is with President Hanan Alphonse. President Hanan Alphonse comes from Rotary of Egypt. She is the president of one of the most prestigious Rotary Club in Egypt, Cairo Nile Valley. And she really has a lot of achievements and endeavors in terms of community services. She is a role model for the slogan, serve above self. And I just a kind reminder that we are not in a competition for Miss Universe, because we have Larissa, we have Larissa now, we have Veronica, and we have Hanan now. We are still in our medical webinar. Now, President Hanan, the floor is yours, please.
Thank you, Dr. Wasila. Actually, I cannot take the floor without thanking IVLA board, mainly Dr. Wasila Taha and Dr. Rashad Bishara. Thank you for the kind invitation. Rotary in Egypt has long history. It started in 1929, more than 90 years with community services. We provide service to others, promote integrity, and advance word understanding, goodwill, and peace through our fellowship of business and professional and community leaders. We are people of action. So on the medical aspects, we conduct well-organized medical convoys to the most unfortunate regions in Egypt, blood campaigns, awareness and screening campaigns for diabetes and its complications, awareness and screening for breast cancer for young ladies. Congratulations for such successful webinar, touching a taboo, an underestimated and underdiagnosed medical condition, pelvic congestion syndrome. Recently, it's named pelvic venous disorders. Medical condition having a lot of social impact as it affects young ladies complaining from deep, dull, aching pelvic pain, up to atrocity of escalating pain which can drive to severe, drastic cleft and separation between young couples. Thank you for the efforts. We are all together trying to raise the awareness for such condition for Rotarians as well as non-Rotarians. I'm deeply thankful for the opportunity to be among all of you. Thank you so much for inviting me. Thank you.
Thank you, Professor Hanan. We really appreciate you being with us today.
Thank you so much. The pleasure is all mine.
And now I wish to present our honorary chair, Dr. Marcial Falas. Dr. Marcial is Vice President of Costa Rica Vascular Surgery Association. He's member of American Venous Lymphatic Society, member of ISTH, and he's editor on Costa Rica Journal of Cardiology. Please, Dr. Marcial.
Hello, everyone. It's a real pleasure for me to be here. It's an honor to be invited to be a part of this amazing meeting. And it's very interesting to see how this have evolved the situation with the CDT treatment. And we can see that we have more studies that give us like more information, but even when we have this information, it helps to have like more questions. It makes like popping up more questions. And we have seen that we don't know exactly when to use the stents. We have used it in some patients, but we have seen that there is no need to use the stents in all the patients. We also have a lack of information to see how we will treat the patients after the treatment. And I mean about the medication that we will use. Some people like to use with low molecular weight heparins, and some people like to use the DOACs, but we don't have information to respond those questions. Another of the questions that we have and that I have seen in this presentation is if we have to decide to do the treatment, specifically looking at the location of the disease, or if we have to go with the symptoms of the patient, because for what I have seen with the Dr. Comarota presentation, we have to look to see what will be better to use, and we have to look especially for the most effective treatment, because we have many devices and we have more devices coming to the market. So we have answered a lot of questions with these papers, but also we have a lot of questions that are coming out after all these papers. So it is very interesting to see the presentation of Dr. Camarota.
Thank you, Dr. Fallas. We are very pleased to have you with us today. It's my great honor to present Professor Mark Whiteley. Professor Mark Whiteley really needs no introduction. He's consultant venous and consultant phlebotomist. He's executive chairman of Whiteley Clinic. He's visiting professor at the University of Surrey. He's founder of the College of Phlebology. He's on the editorial board of the editorial board member of the Journal of Vascular Surgery, Venous and Lymphatic Disorder. That's the most prestigious journal for venous and lymphatic disorders. He's on the academic editor of the Medicine Journal, and he's member of the UIP Educational Committee. Really, I need another 2 or 3 pages to introduce him. Professor Mark Whiteley, we are very pleased to have you with us today, and the podium is yours. Please go ahead.
Thank you very much for that lovely introduction. I'll just share my screen. I hope you can all see that. So today I've been asked to speak about the pelvic congestion syndrome. And as you've heard, this is quite difficult now to talk about. Let me just, if I can just pass back. So firstly, to say the pelvic congestion syndrome is really too big a subject for a 12-minute talk. So what I'm going to actually look at today is the key points in our current thinking of pelvic congestion syndrome, because I think now, just as with everything, 20 years ago when I started presenting lots of work on pelvic veins, a lot of people ignored it, and slowly we've got to the stage where not only is it becoming a big subject, but we're now understanding how big the subject is. So today I'm just going to present some key points and what we're now thinking about pelvic venous congestion. If I'm not quite as articulate as I normally am, this is the reason why. This is Stephen, who is now 8 days old. And so I'm getting some sleep, but not as much as usual. So looking at pelvic congestion syndrome, we have many definitions, and most of the definitions that you will see in the literature are still based on chronic pelvic pain, on pelvic varicose veins, and we almost always talk about women, and we talk about parous or multiparous woman. But the trouble is, as we're learning, that's only the tip of the iceberg. We're finding pelvic congestion syndrome in nulliparous women, women who have never had children, and in fact, very young women who have clear pelvic congestion syndrome. We're finding women who have no symptoms at all inside the pelvis, but are suffering from pelvic varicose veins on the outside, particularly vulval and vaginal. Both men and women both get hemorrhoids and piles, and we've published a paper showing the link between internal iliac vein reflux and hemorrhoids and piles. We know that you can get leg varicose veins in women from pelvic congestion syndrome or pelvic venous reflux, but also, as we've recently published, we also find this in men as well. So this is not only a women-only problem. I mean, you can also that because, as we all know from when we go to medical school, men get varicoceles. And of course, one of the early names for pelvic congestion syndrome was female varicocele. So we know that varicose veins around the gonad is a varicocele. In a man, because it's on the outside, we give it a name. On a woman, it's this mysterious thing called pelvic congestion syndrome. And of course, as we've found from Shiram over in Singapore, has been doing some fantastic work on male erectile dysfunction, showing that if you have male pelvic congestion syndrome, not only can you get your pains, but you can also fail to maintain an erection, not due to arterial inflow, which is the traditional Leriche syndrome, but because the blood is getting into the erect penis, but isn't being held there due to the venous disease allowing it to leak out. So this is not a problem of women. It is not a problem of women who have had children. It's a problem of both sexes with specific problems rearing its head depending on patterns which we don't fully understand yet. Now, if you haven't read this yet, I would highly recommend this. This was fantastic piece of work that was pulled together really by Zaza, who's one of the panelists today, who asked me to join this a few years ago. And I think this is a really fantastic piece of work looking to the UIP, the diagnosis and treatment of pelvic congestion syndrome. And with all consensus documents, it has lots of different ideas in it. And with all consensus, everybody had their say. And it's got some fantastic ideas, although, as I say, everyone still has their own views, which is what I'm going to talk about as well. One of the things that's in this is pointing out, as you've already heard from Hanan earlier on, pelvic congestion syndrome is probably not the best name. It says in here it is recognized as incompletely characterizing the full pathophysiology and presentations of diseases of the pelvic venous system. I think that's totally correct. We should probably drop this term. The only difficulty is, of course, is it's now entrenched in the public, and it will take a long time for people to think of a different name for this and still consider it as the same problem. A couple of the terms I think that were also put in this paper, either pelvic venous disorders, pelvic venous disease, have been proposed. This, when we produced the consensus document, we hadn't decided on anything, but I do think pelvic venous disorders is probably what we're going to call it. This is the book I published last year for general practitioners and the public on pelvic congestion syndrome. And to hedge my bets, I called it also chronic pelvic pain and pelvic venous disorders, because I wanted to make sure that everybody knew what it was about. And in this, I know that we've had several different classifications put forward from different people. But in this book, what I suggested at the moment, and I'll try and justify this a bit later on, is that it's quite simple for this point in time, that we should divide as all medical problems into symptoms and signs. Of the symptoms, which we call 1, we have those either inside the pelvis or those outside the pelvis. And for signs, we have those that are on the pelvis or lower abdomen and those in the legs. To that, we have to then also add a little bit for understanding as to which is reflux and which is obstruction. Because there's in our own practice, we think that almost everybody is reflux with some small amount of obstruction, but there are other papers out there and other experts who think it is almost the other way around, and obstruction is more important. And this is one of the reasons why there is no true consensus at the moment, because we really need to look further into this disease. So if we look at the 1A, the internal pelvic symptoms, these are your typical ones that we know of as pelvic congestion syndrome: irritable bowel, irritable bladder, most importantly, a dragging or an aching or a stand when you're standing or sitting, pain on sexual intercourse, which must be deep, not superficial, chronic pelvic pain or herniated fossa pain. But most importantly, all of these conditions can be felt with other conditions. So we must exclude other pelvic pathology before we can make a positive diagnosis. We also know that about 1/3 of all women with chronic pelvic pain in any gynecological outpatient, it has got pelvic congestion syndrome due to pelvic pains, but is currently rarely diagnosed because most obstetrician gynecologists still do not recognize this. And certainly in the UK, it still doesn't appear as one of the differential causes of pelvic pain at the Royal College of Surgeons, Obstetrics and Gynecology, which I find unbelievable, but it's true. If we go to the 1B symptoms, that's the external pelvic symptoms. That's pain in the vulva, labia, in the low back is the classic place for this to occur. And also, as we published a couple of patients, you can get hip pain. And these 2 patients that we published in the SAGE Open Medical Case Reports had been told they would need hip replacements. But once they had pelvic embolization for other reasons, the hip pain totally disappeared. So you can get pains that are like somatic pains of the pelvic girdle that are due to pelvic congestion or pelvic venous reflux. We then look at 2A, which are the signs. Well, of course, you can't see signs inside the pelvis, but you have the classic signs on the right-hand side here, which are often due to reflux, as in the vulval vaginal varicose veins and the buttock and perineal veins, or the classic ones, as you can see, up on the right-hand side of the suprapubic or indeed flank veins, which are obstructive. And when you see those, we all know this is an obstructive picture, but these are external pelvic or low abdominal signs, so 2A signs. And if you see them in the legs, well, this is where my interest started, we've all now seen lots and lots of these pictures appearing all around the world, Although when I started presenting these in 2000, this was regarded as completely mad because these veins should just be avulsed and nobody was looking up in the pelvis at the time. We now know from things we've published and other people have subsequently published that when you compare people turning up with primary varicose veins, 16% of females with primary varicose veins have a major contribution from pelvic veins. And this really means that if you're working in a vein clinic and you're having patients come to you with primary varicose veins, anywhere between CAAP C1 to C6, and you're not diagnosing pelvic veins, then almost, well, basically 1/6 of your patients are not getting the right treatment, or certainly not right diagnosis. Treatment is something else we have to discuss, but certainly to diagnose this in females is very important. And in males, we had a bit of a discussion, as many of you have seen in phlebology, because although as medical students we're taught that the testicular vein comes down and has no communications in the pelvis, it actually does, and it communicates with the leg, because just as in the female, the veins, although embryologically pulled down from the area of the kidney, do then anastomose with other veins around the inguinal ligament. And of course, internal iliac veins are important as well, as I'll mention in a minute. We published this in 2015 in the Journal of Vascular Surgery, Veins and Lymphatics, pointing out that if you look at the reason people who have had previous stripping have recurrent varicose veins in the legs, a large proportion of them, 1/4 of all together, and 1/3 in patients who have had the, in female patients rather, is pelvic venous disease is a major cause of recurrence. So what are we looking for? Well, we're looking for reflux, we're looking for stasis, and we're looking for obstruction, nutcracker, Maythorn, Nivel. This is the same in all venous disease of the lower limb. 3 things we look for. What we mustn't do is we must not trust poor tests. And basically, poor tests are those tests which are taken when patients are lying flat. Many, many, many years ago, in the 1980s, 1990s, we learned not to trust any test for varicose veins of the legs when the patient was lying flat, because the veins disappear. But for some reason, as soon as we talk about veins in the abdomen and veins in the pelvis, because it's deep inside, we all reach for our MRI or our CT. And depending which of the papers you read, it's either a size of greater than 8 millimeters diameter or 6 millimeters diameter, and the ovarian vein is meant to show abnormality. But as we published in the Journal of European Journal of Vascular Surgery many years ago, back in 2015, if you look at refluxing versus non-refluxing veins, in fact, there is no difference in size. So the days of looking at size of truncal vein are over. We should be looking at reflux. And if you're looking at reflux, you can't be looking at a supine patient. And this is why you must not use the criteria that rest on a patient who is supine. Also, this is we've submitted this recently for publication. We've also shown that just as in the legs, in the vast majority of patients, the reflux in the ovarian veins starts from distally and works proximally. We know this happens in the great saphenous vein. We used to think it started from the top and worked our way down. We now know it's an ascending reflux problem, and we have found exactly the same thing in the ovarian vein. So any of your tests that start looking for reflux up around the level of the renal veins looking downwards, or transabdominal duplex, will miss quite a high proportion of reflux. Even that's just in the ovarian veins, notwithstanding that a lot of this actually comes from internal iliac veins as well, which isn't well seen by transabdominal duplex in any case. This is why we developed, as many of you know, the transvaginal duplex ultrasound. We first presented this in 2000. The patient lies at a 45-degree angle. There's a passive squeezing. We look for passive reflux, we look for reflux on a Valsalva and a Kegel squeeze, and you can see both gonadal veins as well as the internal iliac veins. You can also see communications with vulva, you can see adnexal and arcuate varices, periurethral veins, hemorrhoids, as well as any gynecological problems that are there. However, it is obviously only restricted to females and only restricted to those who consent or are anatomically able to have this. So this is not a cure-all, but we believe and have published that we believe that this is currently the gold standard when we have compared it against venography. This, I think, is one of the most important things we ever published, and we've published this in several guises now, but one of the most important things is if you are only looking at gonadal veins, you're only looking at about 2 to 3% of the problem, because almost every single pattern we see has got the internal iliac vein reflux involved to a major extent. And this is why, if you look along this to the sixth column along, 45% of all the cases that we see who have pelvic congestion syndrome have left ovarian and bilateral internal iliac vein reflux. And many of the patients who fly to us from abroad who have had embolization that has not given them satisfaction is because they've had the left ovarian vein embolized and the internal iliac veins have not been touched. And that's where the massive amount of reflux occurs. Treatments, well, at the moment, treatments are a bit up in the air, but most people are really treating with core embolization, some with plugs. The trouble with plugs, of course, is you don't stop a small circuit recanalization by other ways around. But you can use this with transcatheter sclerotherapy, which is what we use, foam sclerotherapy at the bottom and coil afterwards. And has been pointed in general vascular surgery, there is weak to moderate evidence for this. Other people also use ovarian suppression or hysterectomy. I think hysterectomy should not be used unless everything else has been exhausted. And we are really only seeing patients who have failed the medroxyprogesterone in the first case. Other people have tried other things, such as the Klofraszewski, who believes that you should ignore what's going on inside the pelvis and only worry about the veins that are emerging from the pelvis, which is probably correct for the ones that are going to the legs if you're only worried about the legs. But I have grave concerns about leaving the pelvis untouched unless we're causing harm. One of the things that I have published in my book, and this is a concern at the moment, is that this is where we have to be clear thinking. Everybody's rushing to try and get a grading system before we've actually understood the disease. If we look over here on the left, we have many people, many ladies come to us with the symptoms 1A and 1B, but when we scan them, they have no pelvic vein reflux. And this is about 20% of patients. Now, the trouble with these patients over here is if we didn't test them, we would listen to their signs and say, you sound like pelvic congestion. But then when we look for it, there's no venous cause at all. So not surprisingly, we also have people at the other end who have no symptoms, but pelvic venous reflux. These are the people exactly reverse. We find reflux if we look for it, usually because they've got varicose veins in the legs, but they've got absolutely no symptoms at all. So then when we look in the middle, patients who turn up with pelvic venous reflux found on the transvaginal duplex and also the symptoms, some of these patients will be patients who happen to have pelvic venous reflux and happen to have symptoms for other reasons. But both, just because you have the symptoms and the reflux doesn't mean to say one causes the other. And this is why in almost every reputable paper in this area, you only get an 80% success rate from embolization, or if you need to for obstruction or stenting. You should never get 100% success rate, because to get 100% success rate means that somehow we've got around this problem of patients with reflux and no symptoms, or patients with symptoms and no reflux, which none of us have got at the moment, because none of us understand this. So in summary, Mr. Chairman, ladies and gentlemen, pelvic congestion syndrome, I think we all agree, is a terrible name, and we're probably going for pelvic venous disorders at the moment, or disease. We must remember it encompasses symptoms and signs, and that can be in the pelvis, the abdomen, the genitalia, the anus, and the legs. And we mustn't just think about ladies with this, with pelvic pain. We get it in both women and men, and we get it in women who've had no children, as well as those who have had children. Any test where the patient is lying flat is highly unlikely to be accurate, not unless you are providing some other stimulative cause to make the blood flow. Reflux in our series certainly is much more common than obstruction. We think this affects a very large proportion of the population. I mean, if you look at hemorrhoids, it affects 50% of people in the population by the time they've died, sometime. So we know this is a massive problem. And in the UK, something like 1.5 million women probably have pelvic congestion syndrome and not being diagnosed at the moment. Currently, whatever we say at these meetings, no one really has a perfect way to investigate it in everyone, and certainly no one knows everything about it at the moment. We need a lot of clear thinking when we talk about this rather than preaching. And we also, when we consent patients for treatment, we can't say to patients, wait until we've sorted all this out, we have to be honest with them and say we're doing our best. There is some uncertainty in our investigations. There are alternative treatments, and you don't have to have treatment at the moment, but if you do go ahead, we must tell them about the risks and the possible outcomes. And my belief is that all patients, if they're not all in a study, then we certainly should be putting patients into registries, because it's only by comparing the outcomes, and not only our reported outcomes, but the patient-reported outcomes, as we have in our Venus registry, that we'll be able to get to whether patients are getting good results in the long term. Thank you very much for your attention.
Extraordinary presentation, Professor Whiteley. We're really pleased to have you with us. Really, really nice. We have a little change in the program. Dr. Swat has to leave at 7 exactly. So Sergio, please go ahead.
Yeah, sure. So I will have the pleasure once again of introducing Swat, who is a huge expert also in the field of pelvic. So I would ask him to select the question, but also to give us his perspective, considering indeed his huge experience. Thank you, Swat, and we look forward for being with you in Istanbul in person for the UAP. Bye.
Thank you, Sergio, and thank you, Dr. Rashad Bishara. And as always, Dr. Whiteley gave a very perfect presentation for the pelvic congestion. We know his huge expertise, and in every slide we saw his one article published already related with one question, which is very important in the field of pelvic congestion. As a maybe comment, and I want to ask from him, because the pelvic escape points is really important in the pelvic congestion syndrome. And I think the pelvic escape points are really changing the symptoms related with the pelvic congestion. If these escape points exist in one patient or is not exist in another one due to the passing the pelvic pressure to the lower leg, is I think changing the symptom presentation during the patients visit our clinics. First, I want you to please comment on this, and this I think this is really important. And the one of the most important questions also, which I select from the audience, was that if the patient is visiting your clinic with pelvic congestion and lower leg extremity together, which one would you treat first?
Thank you very much. The first thing, I don't think the pelvic escape points are that important at the moment, because they're only important if you have the signs, and they're being fed from the signs. And at the moment, I presented some data we haven't published yet at the Maastricht meeting, where we find very little correlation between the anatomy and the symptoms patients complain of. The escape points, I think the days where we used to think this is all pressure are not correct. There was a fantastic paper from the professor from Russia, was it Shadrov? I can't believe it, a brilliant paper, which was looking at the possible causes for the pain in pelvic congestion syndrome. And the idea of it being pressure is very, very unlikely. It's much more likely to be a neurotransmitters due to the stasis of blood and inflammation. And so I think the idea that we're distributing pressure and it's escaping is incorrect, because otherwise everyone who had got leg varicose veins or vulvar varicose veins wouldn't get pelvic congestion syndrome anymore, because the blood would be escaping and that would be letting the pain out, which we know doesn't happen. So I think escape points are only important when we talk about how to treat vulvar varicose veins, hemorrhoids, leg varicose veins. I don't think they're really related to the symptoms inside the pelvis. With regarding a patient coming to see me with pelvic congestion and leg veins, so the fortunate thing is the treatment is the same for both. So therefore, I wouldn't need to treat one or the other. If you're going to treat leg varicose veins and they've got reflux from above, just with all venous disease, you treat the top first. So I would treat the pelvic veins first, then the leg veins. Many of my patients who come to me with leg varicose veins that we find out are coming from the pelvis, a major contribution of the pelvis and not the only contribution. And they say they have no pelvic congestion syndrome. And then we treat the leg veins by treating the pelvic veins first, and then the leg veins, say that their pelvis is suddenly much lighter, is better. So symptoms they said weren't there have disappeared because they've got used to them. And this is one of the problems with pelvic symptoms, is pelvic symptoms are not stationary, just like claudication. They come and go, people get used to them, and when you make them better, they often forget how bad they were before, or vice versa. They suddenly get relief from what they didn't know before. So it really is difficult to tease out a good set of symptoms that we know is pelvic congestion syndrome here.
Thank you. I think Dr. Siwat has to leave now. We are sorry to have kept you late. Bye-bye, and have a good time with the other webinar. And now, Dr. Wasila, if you please take over.
Thank you, Dr. Siwat, for your valuable contributions. Thank you very much. And now I'm truly honored to introduce a dear friend, Dr. Zaza Lazarashvili. Professor Lazarashvili from Georgia, he's the medical director for Chapai's Emergency Cardiovascular Center, president of Georgian Association of Angiology and Vascular Surgery, member of the International Pelvic Vein Working Group, and as Professor Whiteley said, he is one of the principal authors of the consensus and the guidelines, and also member of so many distinguished societies. Professor Zaza Lazarashvili, the podium is yours now, Zaza. Unmute yourself, Zaza. Unmute the microphone, please, Zaza.
Sorry.
Yes,
Sorry.
perfect. Yes,
Sorry.
now it's perfect.
Thank you very much, Wasila. Thank you, Dr. Rashad, for invitation, and also Tony and Marks for these excellent presentations. Now is one question to Mark. One of the main goals of our consensus document was to create the basic for unified investigational protocol in reason to increase the homogeneous data from different studies or registers. Still, we have the situation when we looked at there are a lot of different ultrasound protocols of investigation. And from other side, you also described that no one has the perfect way to investigate. What is your opinion? What to do? Which direction? What we must do in future? And also one small question, according to ascending character of the pelvic congestion syndrome, there was only 2 patients, 0.6% of patients which have the reflux in proximal part of the left ovarian vein. Did you check these patients in case of obstructive elements of the left renal vein or not? Thank you.
Thank you very much. So the first bit about that, you're absolutely right. I mean, the thing with the consensus, as you know, because we went through the pros and cons of that, is when you sent it to me and we reviewed and went backwards and forwards. The difficulty is there is no test at the moment that can look at men and women, that can look at reflux and obstruction, because what we're looking at is we're looking at hemodynamics. And the trouble is, image is not hemodynamics. We know this in arteries. We all know it in the 1970s and 80s. We prove it and we don't make the mistake now. We know it in veins in the legs. And we're suddenly having to relearn this for pelvis, things we've learned before, because it's a new area. And I don't have an answer for you, because what we know is we know that CT is not good enough. And the CT protocols with Valsalva, they don't show the internal iliacs very well at all. And we know that transvaginal duplex, even the one that we've developed, doesn't work in men and doesn't work with women who don't want to use it. And it's difficult to, in some cultures, women won't accept it, and quite rightly. And it's an invasive procedure, although not obviously across the skin, but to ask a woman to have a transvaginal duplex is not universally acceptable. But it's the best we've got at the moment. I'm very concerned about a lot of the tests we do that are we think are great, like venography or IVUS, which have no hemodynamics, but we see a nice stenosis. We think, oh, that's fantastic. And quite often we don't stress the vein to check. So one of the things is, you know, we do for outflow obstruction, I really like Chris Latimer's work. And I like the air plethysmography, where you have the patient one way up, have the plethysmography in the leg, then tip them upside down suddenly and see if you get drainage. And many patients who appear to have a stenosis, so May-Thurner syndrome, have absolutely no problem with draining the leg when you tip them upside down. Similarly, we've also won a prize at the American Venous Forum American College of Urology, sorry, a couple of years ago, showing that when we look for nutcracker syndrome, you will quite often see a nutcracker, but if you tip the patient 30 degrees upside down, the nutcracker disappears. And what happens is blood coming out of the kidney, falling down a left ovarian vein because it's incompetent, will actually preferentially go that way and appear to collapse the area that's under the superior mesenteric artery and appear to give a nutcracker. Tip the patient up the other way, and that stenosis disappears. So I'm very concerned about images, even when they're very expensive images, MRI, CT, three-dimensional ultrasound as we use, IVUS, if they don't fit with the hemodynamics that we can see. I would love to give you an answer and say I've solved it. I haven't, which is good also, because it means I've got at least another decade of work ahead of me in publishing. But for our patients, we can only use logic at the moment and the best that we can do. And yes, I think we're not at the stage, the consensus document very much is saying this is where we are now, and this saying this is what's possible. And I think you're right. I think we need to be getting together in 5 years' time and then 10 years' time and, you know, updating it as we discover new ways to investigate these patients. But it's a fantastic area to be in. It's very interesting, but lots and lots of research needs to be done. And we need to listen to the patients, particularly those patients who don't get a good result. We mustn't hide those. They're the ones we learn from.
Thank you very much. I absolutely agree with you. Yes, thank you.
Dr. Wasila, please.
Yes, Dr. Rashad, and now I'm truly honored to introduce our compatriot, Dr. Osman Mahmoud. He's a vascular surgeon, consultant vascular endovascular surgery lecturer in Asyut University, and he's one of the board members of IVLA. Actually, he is the treasurer, and also he is the treasurer of the medical syndicate. So this guy has so many money under his hands. Be friendly with him, please. Dr. Osman Mahmoud, the podium is yours now.
Thank you, Dr. Wasila. Thank you, Dr. Rashad. Hello, everybody. I'm really honored to be with you today. Many thanks, Professor Whiteley. Very, very nice presentation, very elegant and very focused presentation. Actually, I really enjoyed your presentation. I have very short comments. Actually, it's technical points. First one about the hip pain. If we have a patient with a refluxing pain about veins around hip joints, which technique would you prefer during embolization, foam or coil? In that part, highly mobile joint?
So we would only be treating the internal, so it would be on the inside of the pelvis. And what we would do always, as a principle, if it's near something that is going to be mobile, such as the bladder or anything that might be irritated, we do foam first, and then away from the area of mobility, we then do the coil. So it's foam, then coil.
Yeah, okay. Second, what would you prefer for a female with a huge vulval and suprapubic veins more than 8 millimeter diameter? Would you still do sclerotherapy from below, or would you think about alternative coming from above and below, or what's your recommendation?
So you see, what I would do with that is I would think about that exactly the same way as if somebody came to me with a great big varicose vein in their calf, and somebody said, how would you treat a great big varicose vein in the calf? I'd say, well, I want to know, why have I got one? Is it a perforator? Is it a small saphenous vein? Is it a great saphenous vein? Is it? You need to know the underlying cause. Now, if you've got great big vulval varicose veins, that might be coming from reflux in the pelvis, internal iliac or ovarian, or you might just have a dilated vulval vein, which you can have. And the treatment course will depend upon what you find. Now, if you've got suprapubic varices, that's almost definitely an obstruction. And you almost definitely have a May-Thurner or a Nivell, and that patient you need to be so careful with. We published a case recently in SAGE, open case reports, where a lady who had had previous coil embolization went on to have a further child, developed a suprapubic vein, which we thought must be obstruction, but then after delivery, the vein stayed there, but she had no obstruction, and it looked like it developed because of temporary obstruction from the fetus. So we've published that because we did actually end up closing that vein, and because it was external, with that one we used foam sclerotherapy. But I would always caution, always find out what's going on first and treat the internal bit before you treat what's on the outside.
Yeah, that's the same way of thinking, actually. Those patients, we found iliac vein occlusion, and we start to do stenting. And last question for you, Professor Whiteley. Would you prefer to do stenting first, or stenting or embolization?
Dr. Osman, we are, I'm very sorry, but we are late. I have to interrupt you.
I'd say stent first.
Yeah. Perfect.
Thank you.
Okay, thank you.
With this, we come to the last part of this meeting. Very interesting meeting indeed. That's the and this is going to be presented by Dr. Ahmed Kawish. Dr. Ahmed Kawish is consultant vascular surgeon in Egypt and United Arab Emirates. He's lecturer in Alexandria University. He's also the vice president of our foundation. He's medical director of I-Vein Clinics. He's member of the engagement working group of UIP and member of the editorial board of Nepalese Journal. Please, Dr. Ahmed, go ahead.
Thank you, Professor Bishara, for the kind introduction and for giving me this great opportunity to provide the wrap-up for such a brilliant session with two real top-notch speakers and experts in the field. They provided us with really invaluable insights in that area of the deep veins. Digging deep with our first speaker, Dr. Komarota, clearly showed us that iliofemoral DVT is not a disease without sequelae, especially if thrombi were left unremoved. And as they say, a picture is worth 1,000 words. His brilliant, nice photos showed us the whole story of what really happens inside the deep veins when we leave thrombi behind. Therefore, a strategy of early clot removal for acute iliofemoral DVT specifically seems greatly justified, especially after the in-depth analysis of the ATTRACT trial provided by Dr. Komarota, which showed significant reduction actually in moderate to severe post-thrombotic syndrome with improved symptoms and quality of life in thrombolized patients compared to anticoagulated patients alone. And that actually coincides with what we see in our daily practice when we thrombolize patients who actually gain clearly observed benefit, both in the short term and long term as well. However, the challenge still remains in choosing which patients who would clearly benefit from catheter-directed thrombolysis or early clot removal. And flying to our next outstanding presentation by Mark Whiteley. Actually, thank you, Mark, for a great presentation, which actually taught us a lot about pelvic venous disease, and that pelvic venous disorders actually includes a much wider spectrum of disease than was previously thought, using the term pelvic congestion syndrome and thinking about multiparous females only. You showed that it can occur in females and males as well. And you also highlighted the fact that pelvic venous disease can be a major source of recurrence after treating leg varicose veins, accounting for at least a quarter of recurrences occurring in the legs. Duplex ultrasound is the perfect way to diagnose, as you showed us, done transabdominally or transvaginally. However, it still has its shortcomings in detecting obstruction if it's present. So you provided an easy, simple classification as well as algorithm that can guide decision-making in patients with pelvic congestion syndrome. However, in conclusion of this marvelous session, there is no doubt that in the past decade, we have been witnessing a paradigm shift in our understanding of the relation between the pelvis and lower limb deep veins, and much more to be explored and more to be learned as we go forward. Finally, I would like to thank both speakers for being part of IVLA activity, and we are always happy to have you with us online or better offline soon. Thank you, Dr. Rashad.
Excellent wrap up. Thank you. Dr. Wasila, please.
Now coming for the closing part of our night today, we are really delighted having as a guest of honor Professor Hassan Bakr. He is the former chief of vascular surgery department at Asyut University, and this was the first founder for an independent department for vascular surgery in Egyptian universities. He is also the former board member of the Vascular Society of Egypt, the VSE, and Professor Hassan Bakr, unfortunately, he cannot be with us this night, but kindly he delivered a recorded video which will be played by Dr. Rashad now. Dr. Rashad, please.
Dr. Rashad, you need to enable the voice before sharing the video.
We cannot hear the voice, Dr. Rashad.
Lifelong career. After I have, good evening, Dr. Rashad, Dr. Wasila, and all IVLA members. Thank you very much for having me as your guest of honor. I'm truly happy to witness such convention, elegant, informative webinar series. It has been a long journey with vascular surgery as my passion and a lifelong career. After I have finished my training and doctor degree in Strasbourg, the school of Monsieur Le Riche et Monsieur Fontaine, I returned back to Asyut University in 1982 with a mission to start the vascular surgery department. It wouldn't be possible without the help and efforts of my dear colleagues, students. We managed to create a vascular center of excellence, able to serve all vascular patients in a wide region of our region, and to have the lead to make vascular surgery a well recognized specialty with its own trusted training program, medical degree exams across all universities of our beloved Egypt. Alhamdulillah. Thank you again, and wish you all fruitful, productive further sessions. Thank you.
Thank you for this nice recorded message. And we come to the end of this webinar. I would like to thank our sponsors once again, Servier, Medtronic, ECS, Medi, and Promed. Thank you. And our next webinar will be next Saturday, same time. We'll also have very interesting topics. Bye-bye, everybody.
Thank you. Thank you, Dr. Rashad.
Bye-bye. Bye-bye, everybody. Thank you very much. A great night. Bye-bye. Thank you. Thank you, everyone. Thank you.
Excellent. Thank you.
Bye, everybody. Thank you very much for the invitation, and it was a pleasure to see you.
Thank you. We were honored, Marcial.
Bye-bye.
Honored. Bye-bye. Bye-bye.
Thank you.